Well, hello, everybody, and welcome to this session of Ask the Expert. My name is Joel Goebel. I come from Washington University in St. Louis, Department of Otolaryngology. I'm a professor emeritus at this point. I ran the Balance and Dizziness Center for about 20 years. And so we have a wonderful opportunity to discuss a rather challenging topic with one of the world's experts, Professor Jon Stone. He comes from consultant neurologist and honorary professor of neurology at the University of Edinburgh. So, John, welcome.
We really Thanks very much, Joel.
Really appreciate you taking
the time.
So, as you can see, VITA tackles some pretty challenging questions, and these are things that patients ask us and say, "Can we get some clarity?" So that's how we choose which Ask the Expert series to do or webinars, and this certainly is one. This larger topic of functional neurologic disorder, and then particularly as it applies to the more focused topic for our VITA patients, which would be PPPD and posture control. So let me ask you just to start out, since it is a very interesting niche topic, how did you get into this? I mean, where in your training, where did the switch flip that you decided to do this?
Yeah. Well, Joel, I was a trainee in the late 1990s in neurology in the UK. And you're right that it's still thought of as a bit of a niche topic, but actually it's not really a niche issue at all in neurology, because patients with functional neurological symptoms or an FND, we'll talk a bit more about what that is, are really common, and they're one of the commonest things that we see in terms of referrals from GPs. So these are patients with symptoms like paralysis and tremor and seizures, which are really happening, but you can't see them on tests. And in the 90s, I was just really struck by the way that those patients were treated by neurologists. And I'm not critical of anyone in particular, but they were often treated as if there was nothing wrong with them. The tests are normal, so it should be good news for the patient. Or they would be told, "Oh, well, it's a psychiatric problem, go and see a psychiatrist." And I was astonished as well when I opened up my neurology textbooks at that time or journals. There was virtually nothing about this topic. So I got into it from that sort of clinical need, really, of seeing the patients were there and no one was doing anything about it. It also fascinated me. Where were these symptoms coming from? As far as I could see, they were real and very disabling. And the approach we had just didn't seem to be the right one at all.
Right. Well, many of my neurologic colleagues back at the university, if they went into neurology because they liked the search for a diagnosis, and many of my neurologic colleagues liked neurologic disorders that had signs and symptoms. You can actually say you have a blood test, you have a physical exam test, you have something, and say, "Oh, there's the cause." And so I can see in instances like this where you would search for the cause, but then not always can you say you have found the concrete etiology of what your complaint is. Have I got that right?
Well, I know that people do feel like that, but actually, if you think about it, most neurological conditions, we don't know the cause of them. Tell me the actual cause of Parkinson's disease or glioblastoma or multiple sclerosis. We don't know. We can think correlates of the mechanism of those things on a scan. We can see inflammation, but why is the inflammation there? People still don't know the answer to that. And actually, patients with FND do have clinical signs. We'll come on to this later. It's definitely not. It was very much treated as a sort of dustbin diagnosis where you rule out conditions. And then you say, "Oh, well, you must have this functional disorder." And, no wonder patients were upset by that. Whereas, in fact, it isn't a rule-out diagnosis, it's a rule-in. And there are a whole range of typical clinical features for neurologists and other physicians to learn, which have been known about for a long time, but have actually have been forgotten about. There was a sort of long period of neglect and stigma in this condition. So I think what we've been doing in the last 10, 20 years is bring this condition back into the mainstream of neurology, away from the stigma, away from very dualistic ideas, and say, actually, this is just another interesting and important condition that we see in neurological practice.
Yeah, very good. So do you feel that the efforts that you've done over the last few years has penetrated training programs or has penetrated postgraduate programs? In other words, how has the penetration of this disorder gone in the last few years?
I think we're getting there. Compared to when I started, when it was invisible, we have, for example, FND is now a core part of the training curriculum for neurologists in the UK and in the European Union. You see it appearing in all of the mainstream journals, including neurology journals. We have the FND Society, which is an international society of health professionals with about 1,200 members, and lots of patient-led charities as well that are working really well with, like FND Hope, FND Action. So a long way to go, and I think it's going to take decades probably to overcome that stigma that this disorder has. We're talking about a disorder, I almost daren't say the word, but I'm going to say it, a disorder that used to be called hysteria 100 years ago. So you can, just when I say that word, you know how stigmatized this condition has been.
Right.
But I think we have made some progress, particularly with younger neurologists who are interested and want to help and realize this is a disorder and condition that neurologists and a multidisciplinary team can really help, and you can improve people's symptoms, sometimes
Right.
dramatically.
Yeah, well, that's really laudable that it's taken that much work and time and effort to bring this up to the forefront, and on multiple different platforms, postgraduate training and webinars and societies and things like this. So let me just ask you, as a broad brushstroke, what are the more common presentations of a patient that would eventually carry a diagnosis of a functional neurologic disorder? What are some of the common complaints that may fit into this?
Yeah. So before I say that, it's probably worth saying that to distinguish between functional disorders generally as a sort of general category and FND, which is a kind of subcategory of that. So functional disorders are those disorders where what it says on the tin, really, there's a dysfunction of the body or primarily the nervous system causing symptoms. So conditions like fibromyalgia, irritable bowel syndrome, states with persistent fatigue are some of the commonest ones. And FND describes particularly those symptoms that a neurologist might see and relate to movement. So things like paralysis, tremor, and also seizures that are quite common. That's one of the commonest one. And symptoms like numbness. Occasionally we see patients with blindness, speech problems, those kind of symptoms. Those are the sort of traditional FND symptoms. Triple PD or 3PD with dizziness occupies a sort of a slightly uncertain place there. It has been brought under the umbrella of FND, but it also appears in amongst the vestibular disorders as well. But it's a disorder of brain functioning that has a lot in common with the other types of FND.
Yeah, right. Yeah, that was something I wanted to dig into just a little bit later, but I'm glad that you mentioned that. So you have a patient and you're examining them for their complaint, and you're trying to explain that they're falling into this category. How do you counter when they say, "But doctor, are you sure that you haven't missed something?" In other words, to be doubting that there's a identifiable structural cause of everything that I'm complaining of. How do you work with that?
Yeah. Well, the key here is to understand that this is not, as I said, not a dustbin diagnosis. So if anyone's making this diagnosis because someone's just got symptoms and their tests are normal, then they're doing it wrong, basically. The way you diagnose FND is to find typical features of the condition, a bit like you would when you're diagnosing migraine. If someone says, "I've got a throbbing headache, I need to go and lie in a dark room for several hours, I throw up," then we know that just from pattern recognition, that's migraine. You don't make that diagnosis because you see something on a test. Until recently, that's how we diagnose lots of, there are many conditions like that in neurology. Parkinson's disease, for example, doesn't always have a particularly good scan test. It's a clinical diagnosis. So in FND, for example, if someone has a functional tremor, you would do a test called a tremor entrainment sign, where if someone's shaking, you get them to copy a movement, you see that their tremor stops or it goes to the same movement as the examiner. There's a test called Hoover's sign for leg weakness, which enables you to demonstrate that the person in front of you has great difficulty with voluntary movement, but their automatic movement's okay. Or if they're having a seizure, they have typical features of a seizure, like it's a long duration episode with their eyes closed, they're breathing fast, putting the clinical features together. So it is important to investigate patients with FND because they have a high risk of having another neurological condition. So I always tell people, you must think about if you diagnose FND, think what else has this person got? This is relevant to PPPD as well. But I have patients who have FND and MS, for example, where they have their MS is quite mild, but their FND is very severe.
Right.
We can make a diagnosis of FND even though someone does have abnormalities on a scan. So the scan is, if it's very clear-cut FND, the scan is not to make a different diagnosis, it's to see what else do they have wrong with them.
Right.
Changes this whole conversation about, are you sure you haven't missed anything?
Yeah, I was lecturing with one of your colleagues from Edinburgh. We were in Cambridge at the British Society of Otology, and she used a phrase. We were talking about PPPD, and she came right out and she said, "The brain is a liar." The brain is a liar. She was trying to make a point about, the brain is telling you one thing, and yet it's not really that way. But, that's how your body is responding. I thought that was clever.
Okay. We have to be careful with that phrase because that could be misinterpreted, couldn't it? As the patient is a liar, which they're not. But I know what she means.
Right.
And we can maybe come on to that when we think about mechanism of why does FND happen, and actually why it fits with what we know about how the brain works, particularly modern, cutting edge ideas about how the brain works as an organ of prediction. This is a disorder that ought to exist based on those new ideas about how the brain works.
Yeah, good. So how would you differentiate, or where's the intersection in FMD from, say, axis 1 diagnosable psychiatric disease?
Yeah.
Where's the interface?
Well, this is definitely the rub for many patients when they encounter this in clinical practice, because these disorders are mainly seen and present to neurologists or ENTs as well, but they're still classified in psychiatric classification systems. So we used to have this diagnosis of conversion disorder. This was a Freudian idea, that the patient was converting their stress into a physical symptom. And we know that isn't that idea, it's sort of untestable, really. But anyway, it's now been demoted within that system.
Okay.
And the issue here is that we're dealing with a group of disorders that don't fit neatly into a box of the categories that we have. We have this, what people talk about, dualism. We've got disorders of the brain and disorders of the mind. And if you think about it long enough, it doesn't make any sense, because there's only one organ in your head, and there isn't a psychological bit and a neurological bit. And actually, most neurological conditions have a psychiatric dimension. So Parkinson's disease, MS, anything that affects your brain is likely to have a psychiatric dimension. So FND is a disorder that challenges the idea that there's such a thing as a neurological condition and a psychiatric condition. Now that's a bit hard. That sort of blows your mind a bit and gets a bit hard to get your head around. But when people ask me, is it in the mind or the brain, I say that question doesn't make any sense to me, because there's actually only one organ sitting up there.
Yeah.
So another way of trying to deal with this is to say you've got psychiatric disorders, you've got structural disorders that you can see on a scan or test, And then you've got functional disorders, which are a kind of another category. So that's another way of trying to manage that issue, is to say, just think of them as a separate category of human illness.
So that's a good point. And do you find that when you broach that topic, and especially you broach the psychiatric side of that topic, that you get much pushback from the patient? Or by the way that you're able to show it, they understand it?
So I think what's important is to get across to patients. I think at the start of my career, maybe I used to have those issues with patients, but I think more recently, hopefully what's happening is patients can see it's absolutely clear that I'm taking them seriously, and I'm accepting primarily the experience that they have, and I'm not just saying it's all psychological.
Mm-hmm.
So I think when you help people understand you have a condition, other people have it, this is how it works in the brain, this is what's going wrong, here's the mechanisms, then it becomes easier to talk about whether the way that the person thinks about their condition or responds to it could be somehow influencing it. In the same way that if you tell someone that they've got MS, they're usually they actually want to talk about how they feel about that. I've got MS and I feel bad, and this is really depressing, and I'm worried about the future, or I'm frightened of falling. You can have the same conversations with someone with PPPD if you get to the point where that patient trusts you, that you are definitely taking this seriously, and you're not just saying things with secretly in your head, you're thinking, oh, this person's, it's all in their mind. So I think that's probably why I don't have those conversations anymore, because it's clear to people that I don't think that.
Yeah. Well, you've touched on a really fine point, and for all the patients who are watching this, is that their provider, their physician, or that is working with them, or their healthcare provider, whoever it may be, that they understand them, and they understand the symptoms, and they can also work with them, and they're not just trying to put them into a category that doesn't fit.
Absolutely.
Yeah.
One of the key things that I try and get across to physicians is, I think I see all the time, they feel I think a lot of physicians have just not been trained in functional disorders generally. It just hasn't appeared in their medical school. They're not really sure what to do. And then when they graduate, they find there's all these patients who have these conditions, and they don't know about them, what to do. And people talk about othering, they make them something other. And they have weird conversations with them where they start with telling them what they don't have before they've told them what they do. Or they start talking about risk factors for the condition before they've even explained what it is.
Right.
And if we just treat these PPPD, FND, all these disorders just the same as we would migraine, for example, you just say, I know what that is. That's PPPD. I'm going to tell the patient what it is. And then we can have a conversation about why it's happened and what the treatment would be. So I think it's often health professionals that create the stigma or create difficulties in their consultations because they're not confident with it. They're not really sure what it is they're dealing with, and they feel they behave differently around it when they really don't need to. It's just another condition.
Right. Yeah, no, well said. And since you brought up the topic of PPPD, and we can kind of wander into that field, so to speak. We're most used to in the world of Vita, or in my world as a neurotologist, that something happened to the system, a vestibular neuritis attack or a Meniere's attack or some attack, something. And then the patient morphed into this sort of more lingering chronic sensation of imbalance and sensitivity to visual motion, etc. But the definition of PPPD doesn't necessarily have to have that identifiable physiologic trigger, at least if I understand that from the work of the Barony Society and Jeff Staub's group. Am I saying that right, or is there?
Well,
is there almost
it does actually. What it says is typically the disorder follows occurrence of acute or episodic vestibular or balance-related problems. So it is actually in the sort of in amongst the sort of core description.
Right.
I think it's possible to get this without an identifiable origin, but as you say, normally there is one, and normally you can have a pretty good idea what it was: vestibular migraine, BPPV, head injury. So there is usually another trigger which is more identifiable, and I find that, from my point of view, I find that really interesting and important, because that's actually the case for other forms of FND as well, although people are less aware of that.
Right. My question would be, I'm sorry, John.
Yeah.
If you find as a healthcare provider, as a physician, that there's an ongoing disease, physical disease, there's ongoing Meniere attacks, or there's ongoing BPPV, or whatever ongoing, does that pull you out of the triple PD pathway of maladaptation? In other words, there's something that's still physically happening that you can see. You can see nystagmus, or you can see the hearing drop, and so these people are having active, identifiable entities. Do they belong in the triple PD bucket, or should we not do that?
Well, I think we have to be careful that it's not a waste bucket. It's a diagnosis. I think it's a judgment call, isn't it? Where you have to decide, is this person's recurrent vestibular problem? It may be that it's so bad that actually that's the main problem. They actually have vestibular migraine, and we don't need another diagnosis here. They're just having really bad, frequent vestibular migraine, Meniere's. We know that if you have very bad acute vestibular problems, it can take quite a long time to recover from them. So we shouldn't rush to diagnose triple PD too early, I think, because a lot of people are just in a state of recovery from a vestibular event.
Right.
But I think there are people who, and I've met them, who do have, and it's quite common actually, to have triple PD alongside another vestibular condition like BPPV or vestibular migraine, just like I've said earlier about my patients who have FND and MS, for example. So people are sort of a bit uncomfortable with that, but I don't think they need to be. We're very used to, and patients are used to, the fact they may have lots, more than one condition.
Right.
And there's a good reason why having a vestibular condition keeps feeding a functional disorder with similar symptoms.
Right. So could you imagine two separate patients? One patient has an ongoing active vestibular process, but is not responding in that way of feeling dizzy half the days in a month and rocking and visual preference, versus the other patient who has the same identical peripheral process, but they're also morphing into this triple PD path.
Yeah, I think we should be cautious about over-labeling things. I mean, it's a lot to be told you have a condition, and we shouldn't label it unless we think that that a different approach to treatment is going to be helpful. That a triple PD approach in this situation is worth trying. Now, sometimes it's difficult to be sure, isn't it? What proportion of someone's condition is what is related to migraine or related to peripheral vestibular problem versus triple PD. But I think I meet many patients who feel, and this is typical of triple PD, they're at their wit's end with dizziness. It's ruining their life. It's there all the time. Can't get away from it. In that situation, you might say, well, what have we got to lose by wondering how much of this could be triple PD? And why don't we go for a triple PD approach? What have we got to lose is sometimes an approach that I say to patients.
Right. Yeah. No, very good. No, very good. So you have a slide that sort of shows the evolution of thought throughout the decades of patients with this sort of chronic dizziness problem. You want to pop that slide up, Elizabeth?
Yeah, let's bring that up.
Let's see if we can kind of walk through that. That might give patients and even the physicians sort of idea of how this evolved.
So yeah, apologies to there's quite a lot on here, but people had recognized that there were patients who had just continuous, relentless dizziness for over a century, in fact, going way back into the 19th century. So there's more history here, and there have been various terms here that you can see, like Phobic Postural Vertigo, Visual Vertigo, Space Motion Discomfort. And what happened with PPPD was that the international vestibular community came together, I think, really effectively to define this with this new name, PPPD, or 3PD is another quite handy way of saying it. And the key thing I wanted to bring out here is that you can see, yes, there are triggering events. There is persistent dizziness. There are provoking factors. As if anyone watching this has PPPD, you'll know that seeing complex stimuli, maybe like this webinar, apologies, or movement or being in a supermarket makes it worse. Some of the definitions included psychiatric or psychological features like fear or anxiety. Whereas what we're saying now is that you do not need to have anxiety to have PPPD. It's a diagnosis you make purely on the basis of the nature of the dizziness, which, like other forms of FND, it's a rule-in diagnosis. Now, it's not quite as visible and perhaps as some of the other FND diagnoses, but I still think it's recognizable when you see it, when you meet someone with it. So that's that relentless dizziness that usually perhaps not all the time, but most of the time, and it's worse when people are moving around. Okay. So that's how we got to 3PD.
Right. There's two terms that has been used for anxiety. One would be trait anxiety, one would be state anxiety. And in a general broad sweep, I'm not a psychiatrist, but in my understanding, trait anxiety would be something that is sort of wired within your brain that makes you go down that path of generalized anxiety disorder. Whereas state anxiety is a response. It's something that's happening to you and you don't like it. And it's when the airplane plunges 150 feet while you're sitting in the airplane and, your stomach's turned out inside out. Does that play a role in PPPD? I know the anxiety disorder, diagnosis of trait anxiety, but what about state anxiety? What about
both? The answer is that, both can and do very frequently. But I think it's really important for anyone listening to say that you don't have to be anxious to have PPPD. And I meet people where that is the case. But anxiety, I think you meet people who will admit that they've always been anxious, and perhaps it's a strongly genetic trait, anxiety, like migraine. But you also meet people who haven't had that, but they've had the most terrifying episode of vertigo, or happened at the same time as a head injury. So that state anxiety, I think, will often play an important role in deciding whether someone's going to have a transient episode of dizziness from whatever cause, or unfortunately then go on to get persistent dizziness usually long after the initial triggering cause of dizziness has gone away.
Right.
And that's a core concept here, is that we're talking about a condition where it starts off as one thing, like dizziness from a head injury or vestibular neuronitis, and then it merges into PPPD, and the symptoms are the same, but they have a different mechanism. It starts off as a hardware issue, and it turns into a software issue in the brain.
Right. I'm going to step into a little bit years ago when you and I and Aaron Trinidad met in Edinburgh and chatted over this very concept of can we look at a person with a vestibular injury, and based upon perhaps anything we can identify in their personality or anything we can identify in their makeup, can we predict that they would be more prone to go into this PPPD sort of maladaptive state? Can Can you go into that just a little bit? And, you can even mention the study that Aaron and the group is trying to do.
Yeah. So what we did there, so a guy, an ENT colleague called Aaron Trinidad led a study looking at this, where we looked at all the available literature. What was really fascinating was, so we're asking the question, can you predict who's going to get triple PD after a vestibular event? And the things that predicted that was, surprisingly, it wasn't the severity of the vestibular event. So people who can measure things, measure how bad things were, that did not predict triple PD. What did predict them was whether the person early on had, it wasn't necessarily anxiety. Sometimes it was anxiety. Sometimes it was evidence that their body was in a state of red alert. This episode of dizziness had really crashed into them and caused a lot of what we might call autonomic arousal. That seemed to predict triple PD. And the other thing that predicted it was whether they, at an early stage, developed what we call visual dependence. That's where this term visual vertigo comes from. So that they were relying really heavily on their vision for balance, as opposed to their vestibular system or their feet. So those things predicted it. And I think it fits with a model where triple PD it's a disorder where the brain thinks that the injury or the vestibular illness is still happening. It's primed. It's ready to go. It's saying, okay, I'm ready for dizziness, when in fact the cause of the dizziness has gone.
Right.
So that's a hard thing to get across, but that seems to be what's happening.
Yeah. There was a colleague of ours, Dave Pothier, was from the University of Toronto, and he used to use the term catastrophization, that there are individuals that a certain stimuli that was small to other people would be moderate to them, and a stimulus that's moderate to other people would be just absolutely unbearable to them.
Yeah. Well, so I think that can be a useful concept, but I would be a bit cautious about that. When you say that to patients, catastrophization, it sounds like they are catastrophizing.
Mm-hmm.
It's like, it's your fault. You're making a mountain out of a molehill here.
Yeah.
Whereas I think the process of amplification of symptoms, or it's more persistence, actually. I think it's a failure. The sort of dizziness volume knob's turned up in the correct way, and the body's response to it is correct. What's happening is more that volume knob fails to turn back down again,
Right.
rather than the person is catastrophizing about it. So I think that can be a useful concept. We have to be really careful in, I think, not assuming that that's going on in everybody.
Right. Well, that would be, and I can see that a patient would push back on that if it was a conscious effort and say, "Oh, I am consciously doing that."
Yeah.
You're not. Your brain is responding, and it's not necessarily under your control.
That's right. I think, and again, that's a difficult one for patients, because people have the feeling they are in control of their brains, whereas actually we're not. We're not actually, most of the time. We're not aware of what we're doing. So that's another reason these can be difficult disorders for people to get their head around.
Yeah, that's great. Great. So let's go to managing this and treating this. What is the paradigm? Let's stick with triple PD, as a example of a functional neurologic disorder. What treatment strategies?
Shall we bring up another slide of the kind of, there's a sort of map of the causes of triple PD? Yeah, that one. Yeah, because if we look at this might give us some ideas about ways into treatment. So there's a lot here, and you can get this from other places as well, some of the resources that I'm going to give you. But one of the ideas here is, how did people get triple PD, this persistent, horrible feeling of dizziness? It's quite complicated. It starts off with this trigger. The brain thinks that the trigger's still happening. The normal process to shut that down doesn't work, and you get those arrows going around in the middle. People will walk around in a sort of stiff way, as if dizziness could strike at any moment, or because dizziness is striking, other things happen, like you've got up there secondary effects, neck stiffness, fear of falling is very common, worry about going outside because you're worried that you might fall, or that people will be able to see you being dizzy, or they'll be worried that people will think you're drunk is quite a common one, even though, of course, people aren't drunk. And then there are certain situations which make it worse, like being in a busy place, or etc. So, which people then avoid doing. So, if we're thinking about treatment, we have to think about ways. We have to try and be creative, I think, about ways to try and break these vicious circles that are going on. And so, in some patients, they still have a lot of problems moving their head or eyes, and in those patients, I think vestibular habituation exercises or physiotherapy can be helpful. If someone doesn't have any problem moving their eyes or head, I think it's a lot less helpful to do that treatment. We know that because there's been a number of trials that medications, including SSRIs and SNRIs, that are used to treat conditions like anxiety, can help PPPD patients, even if they don't meet criteria for anxiety. So even if you're not that anxious, those medications may help turn this volume knob down on dizziness in some people. But I think we've got to be very careful. We've got to counsel patients about the pros and cons of those medications before they start. So I'm not suggesting everyone should go on medication.
Right.
And then you've got psychological therapies or CBT, which doesn't mean this condition is psychological. You can use CBT to treat fatigue and multiple sclerosis, for example. But I think psychological therapies can be extremely valuable and rewarding in many patients with PPPD. If you get to that point where everyone's comfortable, this is why we're doing them, because we can start to break down and really attack some of the brain mechanisms that are keeping the condition going. The brain constantly expecting dizziness, the brain feeling under threat from dizziness, the fear of falling. Quite often, if you talk to people, they'll realize that actually they have a lot more fear of falling than actually is realistic about whether it's actually likely to happen or not. So getting them to experiment with going out to places that they're avoiding, and then learning to tolerate dizziness or have a different understanding of why it's there starts to reduce that dizziness volume knob.
There was a really good colleague of ours, John, Andrew Clement, was a physical therapist from Leicester. And when I would teach up there in the balance course, he would give his discussion of physiotherapy. And it's not necessarily vestibular rehabilitation therapy in many instances, it's habituation. And he said he would find out what were the conditions, what were the environments that the patient was just absolutely frightened and avoided, and he would take them out of the hospital. He would take them out into the park. He would take them right into the condition and slowly trying to desensitize them to that. Does that make some sense here?
Yeah, so I think that is actually a form of behavioral therapy when you do that. So, and I've said that actually, I think the ideal treatment here is when you can find a therapist, and I know a therapist like that too, and she's brilliant, where you can combine those things, where you're able to do the exercise if you need them, but also go out with the patient into the supermarket, talk about their dizziness as they're doing it. How are they responding to it? Can we get them to respond differently? Yeah. So I've sometimes called that cognitive behavioral physiotherapy. Because I think that it's when you mix it all up, then I think you can really make progress.
Right. Well, from a practical standpoint, what I've learned over the years is that the physical therapists have much more time spent with the patients than we do as physicians.
Yeah,
I didn't have, my visits were never, well, not never. My visits were rarely an hour to an hour and a half long. Yeah. But in the physical therapy world, that's a common time course, and it's in that where they could develop a relationship with the patient, find out what the situations are that really bother them, and then work with them there. And that's why
Absolutely.
what Andrew said, I think, was so vital. Yeah. So this combination of cognitive behavioral therapy being done in the world of physical therapy, I think it's great. Yeah.
And that's exactly what David Herdman and Louise Murden in London did with their trials. So people are doing randomized trials of that therapy.
Yeah.
But it's so important as well that we, as physicians, we often make things worse for patients. We give people really bad explanations of this, make them feel like they're making it all up or they're crazy, and then the therapist has to work so hard to combat that. So there's a lot we can do working as a team, being on the same page.
Right. Well, I think this falls right into the realm of the multidisciplinary approach to a patient. No one of us really has the tools or the wherewithal to do it all, but we work together. So let me ask one last question then, Jon, and we really appreciate the time you've given us. Patient resources. If they're interested to go into this, it's deeper. You've got a society of your own that you can describe. Vito, where would you point a patient if they wanted to go and look at this further?
So I think we've got, if we can have the next slide. Yeah. So I just pointed out a couple of resources here. So we've got this is a website that I've made about FND, which also includes a page on PPPD and a fact sheet there that you can download if you're a patient or if you're a health provider and you want to give people fact sheets. You could try this, which just explains some of the things I've been talking about today. So that's at neurosymptoms.org and it's free. And particularly if you're patient, if you have PPPD and some other FND symptoms, that might be helpful because it describes a lot of other physical neurological symptoms that can occur. For example, some people with PPPD can get a functional gait disorder, which needs a different approach. And then if we can have the next slide. And I just wanted to highlight Vida's own work already on PPPD. You have your own PPPD page there, and a really nice video there that I was looking at earlier. So there are resources. I think we need more. I think we need more for patients. I'd be keen to build them, but it's a start, and it's something. Sometimes these things are quite good to share with your own health providers as well if they don't know about it.
Yeah. Well, this falls under the general category. I've always, when I was teaching the residents, that patients, they really want to be understood. I mean, if your patient feels that you as a healthcare provider really don't understand me, I mean, then there's a wall right there. But as soon as the patient feels that you understand them, you believe them, and you understand them, and you're there to help them. I also tell the patient, I tell the residents, never ever leave the room of a patient without a plan. The plan doesn't have to be permanent, but leave the patient with a plan. And I think the PPPD patient or the functional neurologic disorder patient in general, if they feel understood and you leave them at least with a plan, I think you've gone a long way to trying to help them. Does that make some sense?
Absolutely. I mean, I think it's about patients can tell. I think when a health provider doesn't really believe them or they're just parroting some stuff, and of course everyone wants to get better or symptoms to go away, but it's difficult, and we have to acknowledge that the treatments we have do not help everyone, but some people they can help dramatically. But what we can do for everyone is give them some peace of mind about what's wrong. And in a way that makes it clear that you, as you say, that you do believe them, but without having to sort of over-egg that, because, if you're saying, I believe you too much, patients think, why is he saying this to me? It just needs to be clear that you're making a straightforward diagnosis and you look, here's a description of someone else. That you're in good company here with lots of other people. You've got these conditions. Yeah.
Do you one final question? Do you approach this as a condition or a disorder that you can treat and an overcome, or is this a controllable? It's a persistent but controllable.
Well, I think I feel pretty optimistic when I meet someone with triple PD. Now, there might be someone, my patients watching this, who I've not, still have it. And so, we cannot get everybody with this better. But over time, what's really interesting, I started sending these patients to my neuropsychologist. We talked about how to treat them. They really like seeing people with triple PD now because they have had really good results. I regard it as a disorder that is particularly treatable amongst the FND symptoms.
Yeah.
So, I think that's the way that we should, and that's why we need to look for it in patients who have other conditions like Meniere's and migraine, because we don't want to miss a potentially treatable condition.
Right. Well, you're trained in medical school and in your residencies and your fellowships to look for signs and symptoms and say, okay, well, I can identify that. Therefore, that's all you have. But we miss sometimes what the brain has done with that signal, what the brain has done with that irritation.
Yeah,
how it is adapted correctly or incorrectly. Very good. Any last parting words for anybody who might be listening?
No, I hope that's been helpful. If you're a patient with triple PD or a clinician who looks after people with triple PD, obviously we haven't covered everything, have we, Joel? But in time, but hopefully that's whetted your appetite and will make you want to go and read more about it.
Right. Okay. Well, we really appreciate your time, Jon, and your city of Edinburgh is beautiful. That's probably one of my most favorite cities in the UK. It's magic walking up the Royal Mile. It's magic. So anyway, well, thank you so much for the time, everybody. Thank you for joining us on Ask the Expert, and I hope this was useful to you. All right. Good night.
Thank you. Bye bye.